welcome to another episode of Right Brain Rounds. I'm Dr. Karina Muller, and I have Dr. Heidi Koslow here with us today. She is a doctor of nursing practice, and her focus is family medicine. And I met Heidi quite a few years ago when she worked as a nurse at Providence Medical Center, where I also worked in maternal fetal medicine. And I found it so awesome that we could reconnect after her journey in getting her DNP and to talk with her about autonomy in medicine, talk with her about how she deals with burnout in medicine and things that she can, put out there to our younger colleagues in training about how they can improve their lives during training and also find autonomy in medicine. So thank you so much, Heidi.
Well, thank you. I really appreciate being invited today, and I hope I'm up to the task of addressing those issues for folks. And I do remember you also from the unit, and it was really a very big compliment for me to get a message from you asking to join you for one of your podcast episodes.
Well, awesome. I'm so glad that you can. And, we have a lot of listeners, lots of people who are in medicine. And, the whole concept of this podcast was, as far as Right Brain Rounds, was to help people find creative ways to address burnout and deal with burnout. And, I usually put it out there, music is my cure.
We used to start out, especially when I was the charge nurse on the unit. If you remember that old song by the Black Eyed Peas, tonight's going to be a good night, or we're going to have a good night. We used to make sure we started every night with that song for a while. Good vibes out into the universe, yes. Especially with babies and moms.
So in looking at autonomy in medicine and looking at working for systems versus working in private settings, I know that, we talked a little bit about your work experience after getting your DNP. And I just wanted to, kind of explore that and see, what is the ultimate situation for you in practicing medicine?
You mean my dream kind of thing? What I wish it would be?
Yeah.
I believe that the folks actually doing the practicing and the work on the floor, as it were, the work on the ground, we need to be a big part of the conversation about what's happening in our settings. And often we're left out of that conversation to the point where we have to do things like schedule a peer-to-peer review with an insurance agent in order to get some of the things that our patients, really do need. It's hard for me to understand how we have to make the argument for this is a soft tissue issue. I want a CT scan, or I want an MRI. A plain film imaging is not going to be helpful to me in this situation. And yet the insurance company says you have to go through these steps in order to get to that step. And it ends up being sort of a struggle, and it's very frustrating, where we want you to order this medication's on formulary. Well, the patient said that 3 years ago, when they tried that version of this medication, they didn't do well on it, and that they really need this version that they've come to, and I need to refill that. Well, where's the documentation that they failed that formulary alternative? Buried in their history somewhere, possibly not even quite notated. Why can't we take their word for that? They are part of their care and they know their body. And so to me, that's one of the most frustrating things. And it's worse in the, I think, the setting where the system and the insurance company, the for-profit system part of life. This is recently in the last year, it's the first time I've worked for a for-profit setting, and it's different. It's definitely very hard to get used to, although there were still those limitations in in the federally qualified health center setting, the military setting, but things were easier to get that based on what you felt as a medical provider was the next best step for your patient.
Mhm. And I know that sometimes I run into limitations in what I can offer a patient based on insurance pre-approval, pre-authorization. And then there are cases where maybe I'm monitoring twins to, make sure that they're okay and don't have something called twin transfusion syndrome and have to do specialized ultrasound evaluations. And a lot of insurance companies will come back and say, well, Dr. Muller, that is considered to be experimental, when really it is, for the monitoring of, a very high risk pregnancy. And, trying to talk with insurance companies to say, well, I think I'm going to do it anyway, because that's just the right thing to do for this patient. I've kind of gone to asking for the person's name and contact information so that I can document it in the chart that, different things have been denied, because, there are cases where healthcare has been delayed or significantly altered because insurance does not approve of, certain tests or interventions. And then it's a really big detriment to the patient.
Definitely true. And oftentimes the person making that decision is literally someone who has no experience in the medical field. They're literally an insurance agent who's going down the algorithm. It reminds me of that scene from The Incredibles, where I don't know if you've ever seen that, but he's under his breath telling, we cannot do that. We will not do that here. And then under his breath goes, what you need is Form 2019-2, and you need to do, but we will never help you with that, that sort of thing. And you have to sort of figure out how to do the end run around that. And so many of the things that they tell us are experimental are only still experimental because although we do them commonly in practice, you cannot create a randomized controlled trial where you deny care to a pregnant woman and then do the care for the other pregnant woman and say, well, you're going to get this, and we can't randomize and control those things in any ethical way to make that treatment be considered common instead of experimental.
Right. Yeah, and then, there are some other limitations that I feel like in medicine when we're practicing, that are not placed on us by insurance companies, but maybe more administrators, algorithms, protocols, things like that. Have you seen things like that in your career?
Oh, absolutely. I've one of the things that I did actually, I know we're going to get to burnout. I left a setting just to do some locums for a while, and until just recently, that's what I was doing. And I worked at a place in South Dakota, and their protocol or their policy for birth control, any birth control, but particularly Nexplanon or an IUD, because those devices are more expensive, was to have someone come in, take a urine pregnancy, they had to get a serum pregnancy test, come back in 7 days and take another one before they were allowed to have an IUD or an Nexplanon placed, which makes no sense because I said the same negative pregnancy test we're going to get today may not still result positive by blood in another 7 days, or she may literally have sexual activity in between now and then. And so you're still going to have a negative pregnancy test, but you've just delayed that care. And I pointed out in their protocol, they said per manufacturer's directions, you have to get a serum pregnancy test for insertion of an Nexplanon. And I said, actually, I pulled that policy or that protocol from the manufacturer. And what they say is you need a negative pregnancy test. Nowhere does it say you need a negative blood test and to repeat it in a week.
Mm-hmm.
So instead of changing the protocol to be appropriate on site, to just get a negative pregnancy test so you could help people get their birth control the same day, particularly teenage girls. I dealt a lot with teenage girls there. They changed their protocol to say that without the words the manufacturer specifies you need to do this. They just said this is what we're doing. And it was all because they had one provider who one time put in a Nexplanon on somebody who took a negative urine pregnancy test. And actually, it was just too early to tell that she was pregnant. So it didn't come back positive. And the provider insisted it would have if it was a serum pregnancy test. So that's what we're going to do now. And that's not even necessarily true. So, just getting those protocols, and they're sometimes even outdated. This is not going to be helpful. So, but it's a frustrating thing. So that's one of the biggest examples that I can remember recently, is that instead of actually doing evidence-informed medicine and counseling on this issue, they simply changed their protocol to be what this older provider who was about to retire wanted to do.
Mm-hmm.
So,
yeah. And then, when you think about going to different places and seeing a lot of different settings as a locums, professional, that could be pretty interesting too. You could probably learn a lot and take a lot of good things away with you, and a lot of things that could be improved on away with you for your next, position. So do you feel like that's true with doing locums?
it was true. I've made some good friends that way, some people I definitely respect. And I'm like, if I could just put together my dream clinic and just transplant everyone to this one spot, the folks that I would select, and some of the things I learned, why are they still doing it this way? This is not the recommendation. It's not evidence informed. It's not appropriate. And having to prove myself, literally look things up and show people things when they should be responsible for staying on top of, as individual providers, as well as a system. That's frustrating to me. In that particular case, that they didn't want to do that. There are lots of places they run things how they run them, and it's the old, well, that's how we've always done it mentality. And because that's how we've always done it, that must be right.
Yes. And then, sometimes in different clinical settings, you have people that are making these protocols who might not even be in clinical medicine, or, making schedules that sometimes don't make sense, or, capping or saying you must see this many people per day, or, trying to make people get certain RVUs done, or have, protocols where people who might live in rural areas need to come back to clinics and be seen more often for, different things that, might be able to be done remotely or via telemedicine or phone. Have you seen things like that happen too?
Absolutely. Part of the problem in some of the settings I've been in is, resource poor areas. We deal with this in Alaska, that outlying areas just don't have the bandwidth and the power sometimes to do some telemedicine things we'd like to do. And that was also the case with a couple of the locums systems that I worked, when I was at different places with locums, is, but they also don't have the transportation to come in.
Mm-hmm.
So there's no good solution that the site comes up with other than scheduling them and then no showing them when they just can't make it in, and sort of becoming the ambulance at the bottom of the cliff, where the next time they come in, you end up having to transport them to the emergency room or the emergency room an hour away because the local hospital is not adequately prepared to deal with them. The one place I was working, we shared the ultrasound tech in the community between our clinic and the hospital. And that person can't be available 24/7. So you'd think you'd be sending somebody, well, we don't have ultrasound here and we don't do emergency ultrasounds, but I'll send you down to the hospital. And they would show up there and that person wasn't available either. So, it gets kind of spread thin. And some of those things, community transport, you need a bus system, you need some sort of transport to get people to where they need to go, or some other solution. And telemed has helped a lot, but I know I have issues sometimes with people's connections getting dropped. They don't have the technology. They're a brand new patient and they have not uploaded their medication. There's just nothing to go on, and then don't understand why you can't give them their Xanax or their, oxycodones that their other doctor always gave them, or whatever it may be. It could just be their blood pressure medicine. Well, when's the last time you had labs or saw somebody? Well, maybe 2 or 3 years ago. I can't even legally really do that.
Mm-hmm.
So, our infrastructure in this country, and I know in Alaska, it's relatively poor as far as transportation for people from outlying areas. And when they are transported, I know even ANMC struggles with this, is they might bring a pregnant woman in and she has to wait there for a month or longer till she's ready to give birth, without a support person. And, very lonely, maybe on bed rest or whatever's going on. She's supposed to have limited activity, but she has no way to get around to do anything because she doesn't have a support person. There's just all sorts of issues around that I really struggle with our healthcare system in the United States, particularly. But I'd love to see it get better. I feel like I'm going off on tangents for you that we didn't necessarily go for, but
No, it's totally, all of these things can overwhelm, the different people who are providing services in the medical field. There's so many different facets of how patients receive care, and, to look at each system and say, okay, this works, this might not work so well, this definitely doesn't work, and try to be a champion for both, the practitioners and their health, but then also how that trickles down, and that when, people are healthy and not burned out and not, just overwhelmed by things that happen in systems, that their patients overall are the ones who are benefiting from the health of their providers. And so, in looking at that and thinking about opportunities for burnout prevention, resilience in medicine, have you found anything that helps you as far as, dealing with burnout, or maybe taking a break from work, or the stressors that can surround someone in clinical practice?
one of the things, well, first of all, I got a little bit burned out where I was. I loved the military health setting, but there really wasn't any climbing higher room for systems change or management type things. So I did locums for a while and that really helped. And then sometimes just thinking, all I have to do is get through this next shift, keep my people, at the end of the day, did anybody die? No. Okay. One of the things as far as on site, where I am now, there's no direct line into the clinic. They have a call center and they have a group of clinics in the area, but they have a MyChart or a portal system where people can send messages to their provider. And I actually find that getting a direct contact from a patient to ask a question is so much easier for me than what the system's preference is, which is whisper down the lane. You call the call center puts in a message, they send it to your patient care coordinator that's assigned to your group, And then the patient care coordinator sends you the message. And so often I have found that, of course, it's mistranslated. What does this patient really need? What are they asking for?
Mm-hmm.
And so one of my workarounds to avoid that here is just saying, hey, in your portal, you should be able to pick me. I'm your primary care provider. You should be able to send me a message. And I don't work every day, but that might help. I like the setting from the standpoint of I do work 3 12s a week or 2 12s and 2 8s if it's a weekend. We're closed. We're only closed like 2 holidays a year. So the idea that access is there, but I only have to provide it for, I have to provide it for 12 hours, but I usually have several days off in a row. I have breaks, and that helps a lot. I do things like walk. I have a couple cats, a dog. We take walks. He's an older dog, so it's a good walk for me and for him because he's not pulling me around anywhere. He's pretty well trained as well. But, and one of the weird things, well, not weird, but one of my hobbies for life has been cross stitching or needlework, sort of artistic beadwork, that sort of thing. So, so I do some of those things on my time off. I do have an Alexa, what are they called? One of those little things, a dot, that I can play music at work. And they actually do allow that. They don't allow personalization of your space where I'm at. You don't even really have an office. You literally have a little stand for your computer and a rolling stool. But so I personalize what I can, personalize my desktop background and have my song picks. And sometimes you just have to say, I just have to get through this next one thing. And I'm going to do what I can do while still making sure I'm not going to leave the patient in a room without truly what they need. It may not address everything they came in for that day or wanted to get done, but let's address that top need and make sure you're safe for yet another day, if that's what it takes. And that's, to me, that's very important because the patient is number one, but I'm standing right next to them and they're not going to have me at all if I crack up and quit and have to go live in Siberia somewhere.
Mm-hmm. And I think sometimes too in medicine, it can be taboo to ask for help. Making sure that that patient is taken care of and that, nothing, horrible is going to happen to them and that everything that they've been talking to you about is addressed. I wonder how we can make sure that as practitioners, we're all heard as well in systems and that what we need is taken care of, our basic needs, the hierarchy of needs, and to make us feel safe.
And for me, I'm pretty outspoken, so I don't have a problem with asking the questions that say, what is the rationalization? I try not to ask why. Why are we doing it? Because it's very confrontational. But what's the rationalization for us doing it this way? This doesn't make sense to me according to evidence-informed practice. Or, yeah, I do need help with this patient. I need somebody to help find these resources because you want my productivity or you want my RVUs here, and I can't do that when I'm still dealing with this. So I need you, Mr. Manager, or you, my medical assistant, I need you to make this call or this call and find this out or get that physician on the phone for me so I can dialogue and see what do you need done for your specialty that they're not sure what it was called, but we need to get that done for their pre-op or whatever it may be. So, not being afraid to, I like to get direct messages from patients. It's not exactly the same as also saying, okay, I don't need to be doing this particular thing. Can you do this for me? Please get this information. I specifically need you to ask this question. I don't have time to wait on hold to find out the answer to that sort of thing. So asking for that help and remembering to look things up and to always be figuring you're going to learn something new every single day. Look for those things you're learning every single day. I don't care how long you've been in practice.
Yes, lifelong continuing medical education.
Yeah.
That's the
Well,
field that we're in.
sometimes just learning things from patients, you know, learning things like, I know you're probably familiar with this. We worked in the same unit even for a while, but understanding those adverse events in their histories and how to avoid triggering those things, even if you don't know if they've experienced that or not. Do you remember way back in the day, Brittany, maybe even before you were a physician and you were a patient, they used to train medical people to glide their hand down the inside of a woman's thigh before they did their PAP, right? Okay, here I am, I'm coming. Well, I talk my way through it and I tell them where I'm about to touch because that's a very triggering event. And even some of the words we use, so learning all of those things, and sometimes from patients and making sure patients feel empowered. If you don't like what I'm doing or you need me to stop, tell me. You have control of this. And I feel like when they have control, then we end up doing better together. So those things help me too. And I learn something from every patient about their experiences and from my MAs, or if I have students, I am always saying, okay, just ask me whatever you want to ask in the room. It's okay. Because if I don't know the answer, it's all right to not know all the answers and to say, I'm going to have to refresh myself on that, or I'm going to actually look that up again. I don't remember the exact XYZ related to that. And look it up. And don't be afraid to do that.
Mhm. I think too, when, kind of going to that question of, should a medical student or a student ask a question of a preceptor in front of a patient, showing patients that we actually have a human side and that we're not afraid to admit when there's something that we might need to look up. I mean, it's totally a humanizing situation. And, you didn't get to where you are because you don't know what to do. If there's ever a situation where you don't know what to do, you can look it up, you can ask a colleague, you can talk to someone. I mean, it's not, I guess some, providers might always know the answer.
Or think they do.
Yeah.
I like to tell people, if the day I go through without looking something up, double checking something, et cetera, is probably the day I should hang up my license
Yeah.
and put it away, because we don't know everything. We don't remember everything correctly. The other thing that I like about doing that too is showing patients how to find reliable information, because I take my laptop, I work off of a laptop, and I take that into exam rooms. I let them look in their chart with me. What do we need to add here or there? And how to find information and not just go down the Google rat hole or sinkhole it might be of, how do you might need to come see us because we have access to some resources that you do not. But here are some reliable sources you can get access to read more on this. And I think it is humanizing, and it is a reminder that we didn't get where we are by just absorbing it all up and being a sponge, and now we have everything stuck in here. It's because we say we know we're capable of forgetting things or misremembering them, and we double check.
Yeah.
And they have the permission to do that too. So, and then I usually find those kinds of folks, they want to come back to me because I didn't treat them like they were somehow stupid or incapable.
Mm-hmm. Yeah.
And we learn new words together.
Yeah.
Sometimes.
Yeah. In that learning process together, I mean, I would think that a patient, if I had a physician or, a nurse practitioner taking care of me, and I knew that we could learn together, I could ask questions and not be afraid or feel less than because I'm asking that question. And, when you think about going to a medical appointment, it can be anxiety provoking. And
it is for many patients.
yeah, and to ask those questions without feeling like you're, saying something stupid, or, going in to talk about maybe something a very sensitive subject like sexual dysfunction. I mean, how many people
Right.
want to bring up a, situation like that, to their practitioners? I don't know of many.
I think a handful of times, and although I've worked a lot in maternal child health and pediatrics, and that doesn't necessarily really count, but I don't think I could count on one hand. I don't think I have enough. I mean, I think I have too many fingers
Mm-hmm.
that people brought that up as the thing that, unless they were just getting a refill on their little blue pill, as they like to call it, that they've already been on, and then it's rather self-explanatory. But
Yes.
yeah.
Yes.
And particularly women, I think, really struggle with that.
Mm-hmm.
Certain sensitive subjects.
Mm-hmm. And, if you could put out there words of advice for people who are in training, people who are going into medicine, how can they best move forward in their career, like after COVID, or if they're facing burnout? Do you have any words of, encouragement or advice for those in training?
I guess it's going to depend upon who you are, but for me, I definitely, you'll hear my voice. Also, though, realizing when it's inappropriate and remembering to apologize, but just finding something that gives you joy, if it's a little bit at a time. I will tell you, back in nursing school, the rule was we had to wear white shoes and white socks. And I thought to myself, who is ever going to have me pull up my scrubs to double check my socks? So socks were my fun thing. I'm going to do this. I'm going to wear socks that make me happy. And I know that's a little thing. Sometimes just finding that tiny little joy, if you can change nothing else, what is the one thing you do have control over? They don't know if you're wearing, briefs with little smiley faces or Snoopy or whatever all over them. There's just certain things that don't need to be in other people's control, and you can still control it. And then, choosing your attitude is true. And also just you're worth more than if somebody really tries to downgrade you or denigrate you in front of others. You're worth more than that. And talk to somebody, do whatever you need to do to go home and get through that, and not internalize that. And that's all easy stuff for me to say, but that's some of the stuff that I've had to deal with externalizing instead of keeping internal. Not everybody is going to like you, and that's okay. And it's, what do we like to say I'm Gen X, so it is what it is. And it's okay to sometimes say that and just it has to slide off your back. Find something you enjoy doing. It could even be fidget toys are the whole new craze right now, like all those fidget toys in the last decade or so. Mm-hmm. Something that makes you happy. Go find that really friendly nurse on the floor somewhere that will, I used to love having the residents come around, because I'm like, we can teach them something, and we are going to learn something every time we talk to one of them. They'll be excited to tell us something. And that's how it should be for everyone. Always find something to share and find somebody you can click with.
Yes.
And find your joy.
That's so true. I mean, there are limited times for people in training to sleep, eat, take care of themselves. But if they can set aside some time to do something that helps bring them joy in that long journey to become someone who can take care of others' lives, I mean, it's such a privilege to do what we do. That those are just great words of advice.
Well, I hope they help somebody. And you're going to have days where you feel like you can't do any of that. And then another day is going to be better.
Yes.
This too shall end.
Exactly. It's like continuing medical education on how to take care of ourselves.
Exactly. Exactly. Always revisit that topic.
Yes. Well, Heidi, I've so much enjoyed our time together, and I really have also enjoyed, the pearls of wisdom that you've been able to put out there, and hopefully it helps someone. And that's what we're here to do here at Right Brain Rounds, is provide creative solutions for burnout and, success in the medical field. So thank you.
Well, I hope someday I truly 100% feel successful, but every day I get a little closer. Just like I'm going to live forever, and so far so good. You're always growing. I really appreciate it. I've enjoyed reconnecting with you, and I hope we can stay in touch better.
Yes, let's do it.